It's 1 o'clock. We're going to give everybody a few more minutes to join in, and we'll be starting our webinar soon. Good afternoon, everyone. Thank you for joining today's webinar by Trend Health Partners. My name is Michelle McBride. I'm the Director of Nursing with Trend, and joining us to walk through the various topics are a panel of expert registered nurses that are on our nursing team that include Rebecca Hudson, Angela Puckett, and Mona Blankenship. Today we'll be discussing inpatient versus observation level of care, how to determine the appropriate level of care, and different situations affecting the determination. We will allow for questions at the end of the webinar. So if you have a question, we ask that you submit it through the chat, and we will answer as many as time allows. I'm now going to turn it over to Rebecca Hudson to begin our presentation.
Hello, everyone. I will be reviewing the facts on inpatient and observation level of care. Inpatient level of care is when a patient presents with a serious problem that requires a high level of medical care. Admission to inpatient status is only justified and only compensated for patients who are expected to need hospital-based care for more than 2 midnights, and whom receiving care in a less intensive setting would pose a risk to their health or well-being. Observation is appropriate when there are symptoms that require short-term monitoring and to determine if additional care is needed in an inpatient setting. Observation care is usually not expected to exceed 24 to 48 hours without discharge or admission. When a physician orders that a member be placed under observation, the member's status is that of an outpatient. Observation services are considered medically necessary for short-term monitoring that is expected to require at least 6 hours of assessment or treatment and improve significantly within 24 to 48 hours. Inpatient versus observation comes into question with denial management when the length of stay is 0 to 3 days. There must be documentation supporting the severity of illness along with comorbidities for inpatient level of care to be supported. Clinical determination is based on evidence-based guidelines such as Milliman and Interqual, payer policies. Certain payers have policies on observation and short inpatient hospital stays, and CMS policies, including the inpatient-only list and the 2-midnight rule. Next slide, please. Here we have listed some of the common diagnoses that are usually denied for inpatient level of care, especially when the patient has a 0 to 3 day length of stay. Some of the most common diagnoses in this category would be chest pain, abdominal pain, asthma, cellulitis, and altered mental status. An example would be a patient presenting with abdominal pain, nausea, and vomiting. They receive abdominal imaging, IV fluids, and antiemetics, and abdominal pain improves within 1 to 2 days, with no concerning findings on imaging. This patient is appropriate for observation level of care. Next slide, please. Here we have listed some common diagnoses that are often denied for inpatient level of care if they are not associated with severe findings, complications, or comorbidities. An example that we see frequently would be sepsis. The patient must have evidence of end organ dysfunction with an elevated SOFA score. Organ dysfunction can be seen with acute kidney injury, altered mental status, hypoxia, and thrombocytopenia. The patient's baseline cannot count towards this, meaning chronic kidney disease with a baseline elevated creatinine does not count as acute kidney injury, or a patient with baseline dementia does not count towards altered mental status. The change must be an acute finding. Next slide, please. How to determine if the patient's symptoms meet inpatient or observation level of care. There are several factors to consider. How did the patient present? Look at the ER presentation, severity of symptoms, treatment received in the ER, and the patient's response. What is the patient's baseline? Does the patient normally wear oxygen at home? Do they have chronic respiratory failure and hypercarbia? These findings cannot be used as an acute finding if the patient chronically has them. Does this patient have comorbidities that complicate the problem? Examples would be malignancy and active chemotherapy treatment, chronic lung disease with ongoing steroids, or a transplant recipient receiving immunosuppressive drugs. All of these can increase a patient's risk for serious disease. Is a serious problem present or undetermined? Rule in versus rule out. Certain diagnoses are considered rule out diagnoses. An example would be chest pain, rule out MI. Does testing confirm MI, such as elevated cardiac enzymes and EKG changes, or is further testing required? Did the patient have an inpatient surgical procedure? Certain procedures are considered inpatient only per CMS guidelines, and these are listed on the inpatient only list that is updated and published each year. These procedures are only considered safe to perform in an inpatient setting as they are more complex, have a higher risk of complications, and require more intensive postoperative monitoring. Next slide, please. When looking at a patient's presenting symptoms, there are certain symptoms that are generally safe to treat in observation level of care and some that require an inpatient level of care. Observation level of care is appropriate for patients who are hemodynamically stable, require ongoing monitoring, and possibly specialty consults. Some examples of symptoms and treatment appropriate for observation level of care would be shortness of breath, abdominal pain, and headache. These can be treated with supplemental oxygen, imaging, IV fluids, pain control, and IV antiemetics. Next slide, please. When considering inpatient level of care, consider patients' comorbidities that increase their risk, such as age, frailty, and concurrent diagnoses, such as COPD, chronic kidney disease, diabetes, and heart failure. Some examples of diagnoses with symptoms that would require an inpatient level of care would be new onset heart failure with dyspnea, orthopnea, and rales, respiratory distress with increased work of breathing, cardiac arrhythmias such as VFib with cardiac arrest, sustained ventricular tachycardia, and third-degree AV block. Treatment that would justify an inpatient level of care would include IV diuretics, dialysis, high-flow nasal cannula, non-invasive positive pressure ventilation or intubation and mechanical ventilation, and IV antiarrhythmics, cardioversion, and placement of pacemaker. And now I'm going to turn this over to Angie, who is going to discuss the 2 midnight rule.
Hello, everyone. I'm going to review some highlights related to the 2 midnight rule. The 2 midnight rule was created to ensure that all patients receive timely and appropriate health care. It states that coverage for an inpatient admission must be provided in the documentation by the physician and based on the consideration of complex medical factors with the expectation the patient will require care that crosses 2 or more midnights. Some exceptions to the two-midnight rule include complex medical factors such as active comorbidities, treatment that was started and then the patient may be transferred to a higher level of care, or the patient died but did not cross 2 or more midnights. This would be an exception to the two-midnight rule. Also, inpatient-only procedures. Those are procedures considered by CMS guidelines to be performed at an inpatient stay. New mechanical ventilation is also an exception. And both Interqual and Milliman include notes related to the CMS inpatient-only procedures as exceptions. Things to consider about the two-midnight rule include many things that Rebecca has already pointed out, but I wanted to expand on a few of these. First, does this patient meet inpatient medical necessity? It does not matter the length of stay if they do not meet industry standard guidelines. Those include CMS, Interqual, Milliman, and of course the payer-specific policies. When doing a review, you want to follow the guidelines used by the payer. How did this patient present? Are they at their baseline? Is this a new acute symptom? If they are in distress, did they require emergent or urgent intervention such as intubation or surgery? And do these symptoms that they're presenting with meet inpatient? Also, did they respond to the treatment, return to their baseline while in the ER during the OBS period? This will affect your decision on whether these patients meet inpatient. Do they have multiple comorbidities that are actively affecting the stay, not just mentioned as a past medical history and continued on current home meds? Will these active comorbidities affect this treatment, this stay? Will it change the traditional therapy in some way that will lengthen this stay or increase the level of care required? And lastly, I cannot stress the importance of documentation by the physician. They need to document their thought process. Using their critical judgment, they must explain why a 2 or more midnight stay is expected. They cannot simply document treatment will be at least 2 or more midnights. The payers want to see the physician's thought process in their documentation. And if they fail to support the medical necessity, then the stay will not be considered to meet inpatient. Now I'm going to turn it over to Mona to go over some surgical procedures.
Okay, good afternoon, everyone. We've listed some of the inpatient versus ambulatory surgical procedures below. The inpatient procedures that we have listed are transcatheter aortic valve replacement, mitral valve replacement, lumbar fusion, posterior cervical fusion, craniotomy, valve resections with or without an ostomy, partial hip replacement related to fracture, gastric bypass, and CABG. More common ambulatory or outpatient surgeries include laparoscopic cholecystectomy, laparoscopic appendectomy, hernia repair, an anterior cervical fusion, tonsillectomy, cataract surgery, cosmetic surgery, gastric sleeve, and total hip replacement. We'll talk about some of the more controversial procedures, because there's always an argument for either outpatient or inpatient on any of these procedures. These are the ones that are just listed as your industry standard inpatient, outpatient procedures. Spinal fusion, the main reason that would be controversial would be, as you can see, we have a lumbar fusion, which is inpatient, and a posterior cervical fusion, which is inpatient, but an anterior cervical fusion would be considered ambulatory. And so we always need to pay close attention to the exact surgery that the patient underwent when we're dealing with the spinal fusions, and not get those also confused with things like laminectomy or discectomy, because those are all ambulatory as well. Hernia repair, simply because we have hiatal hernia, there's so many different kinds of hernias. And those in your industry standards are listed, whatever criteria they have to meet to be inpatient. Normally, any hernia repair other than a hiatal hernia that is done open instead of laparoscopically is considered inpatient. Any other is usually considered an outpatient or ambulatory procedure. Gastric bypass, we have that simply because there's two different types of gastric restrictive surgeries. We have bypass, and then we also have gastric sleeve, which is not nearly as invasive. The hip procedures, they come into question whenever you have the total hip replacement versus the partial hip replacement. And the partial hip replacement is what the patient undergoes most often related to a hip fracture. And then that is considered an inpatient procedure. If it is a partial hip replacement, what did I just say?
Partial.
Oh, okay. Total hip replacement is what's done if the person is usually their hip has, they just need the total hip replacement related to arthritic changes or just a chronic issue with their hip. They will get a total hip replacement, and that's considered ambulatory. And at this time, I'm going to turn it back over to Angela to go over some case studies that we have on some of our claims.
Hello again. I wanted to go over a couple of case studies for argument for meeting inpatient and why they meet inpatient. The first one is a 1-day stay transcatheter aortic valve replacement, a TAVR, for severe symptomatic aortic stenosis. This is included on CMS's inpatient only list, as well as Milliman and Interqual recommend this as an inpatient procedure due to the high risk for complications. A 2-day inpatient stay with a COPD exacerbation with shortness of breath that presents with hypoxia of 80% on room air. They received albuterol nebulizer and supplemental oxygen at 2 liters that required being increased to 4 liters. They were tachycardic at 105, had diffuse wheezing noted, and required IV Decadron and Duonebs given every 4 hours along with Zithromax daily. This would be inpatient due to it being new symptoms below their baseline and up to 4 liters along with the IV steroids. Another one here is a 1-day stay for cyclical vomiting syndrome. This is one of those that is going to fall into the exception for the 2 midnight rule due to the severity of symptoms and the high level of treatment. They presented with hyponatremia with a sodium of 126, a bicarb of 9, and a pH of 7.17. They were treated initially with 3 liters of normal saline, then changed to lactated ringers at 100 cc's an hour, and ended up receiving a total of 7 liters, along with a napsine, Zofran, a magnesium bolus, and phosphate IV. So due to the severity again of this patient presentation, the 2 midnight rule wouldn't apply here because of the severity of illness. I want to go over some observation case studies with you as well. This one, the first one, was a 2-day inpatient stay. They presented with syncope. The likely cause was found to be hypotension secondary to dehydration. There was on imaging no acute abnormalities. They were on continuous cardiac monitoring. They had weight loss noted with severe protein calorie malnutrition. Therefore, they were treated with a saline bolus. They also received 1 unit of packed blood cells, a bolus of potassium, and some IV fluids. This would be considered observation due to this being one of those that was a rule-out diagnosis, likely related to poor PO intake. Therefore, they were treated, they responded, and they were discharged home within that 48-hour period that's considered observation. The next one was a 3-day stay for cholecystitis. They underwent a lap cholecystectomy on the 2nd day of admission. They had no postoperative complications or comorbidities documented to support any of the ambulatory exceptions. This was not considered a high risk. They recovered appropriately and were discharged home without complications. So therefore, even though it was a 3-night stay, observation was still appropriate for this patient. The third one was a 2-day inpatient stay for chest pain. Again, this is one like Rebecca mentioned. They're coming in with chest pain that radiated to the left arm, so we're going to be looking to rule out an MI or some other cardiac event. They had a blood pressure of 140/87. Pulse was 86. They had a saturation of 94% on room air, and their EKG showed atrial fibrillation with no ST changes. Their chest x-ray was unremarkable, and the troponins were negative, ×3, and they received aspirin and nitroglycerin paste. Cardiology was consulted. They underwent a heart cath that did not show any stenosis. Therefore, cardiac event and MI was ruled out. They responded to treatment, their symptoms resolved, and they discharged home on the 2nd day after their heart cath. So this would be appropriate for observation because there was no acute or emergent intervention required, and cardiac event was ruled out with resolution of symptoms. Therefore, again, this would be appropriate for observation. Now we are going to open up for questions. If anyone has any, please put them in the chat, and we will go back and look at the ones that have already been asked.
And I believe we have several that have already been asked, and I also believe that Megan has been answering some of those questions as well. So let's open up now the floor before we address the ones in the chat to see if there are questions that haven't yet been posed. If no one has a specific question, Megan, perhaps you want to read a few that have been posed that you responded to already.
Yes. So one of the questions that was asked was, does a 2 midnight stay mean inpatient level of care? But not all 2 midnight stays are inpatient. They must meet industry-leading guidelines for inpatient medical necessity. Inpatient admissions would generally be payable under Part A if the admitting practitioner expected the patient hospitalization to cross 2 midnights, and the medical record supported that reasonable expectation. The question was elaborated with, so if the patient is progressing, then they are only qualify for observation. And that is correct. If the patient does not meet the criteria listed in the industry-leading guidelines, nor have a complex medical factor, then yes, they would be most appropriate for observation.
So in other words, if a person came in and then they began improving, and continue to improve, there'd be no reason to keep them inpatient. So the meaning of progression here being that they improved over time and the documentation read that way, and they had no additional changes or additional treatment being needed, then they would be discharged home and it would be an observation.
Correct.
Mm-hmm.
We wouldn't have an argument for medical necessity in that situation.
Uh-huh.
And also to elaborate on that, there are a lot of admission criteria that requires a failed observation level of care before that will meet inpatient level of care, such as COPD. If they come in, if they're not actually having a hypoxic event, then if it's just dyspnea or some symptoms like that, then they require that to be failed observation before they will actually qualify for an inpatient level of care. Megan?
Another one of the questions that was asked is if you can code a rule out diagnosis. And in regards to that question, a rule out diagnosis can be coded when the diagnosis is not confirmed prior to discharge. If the diagnosis is ruled out while the patient is in the hospital, then it will be most appropriate to code the diagnosis that is most appropriate for that patient.
That's right. That's right. Because you can code a rule out. But if you've already ruled it out, then it's no longer ruled out. It's ruled in.
Yeah.
And so as Angie had talked earlier about rule out and rule in those diagnoses, just an example that someone that may be a coder might have had there in those indications. But if you did rule it in, while the patient's still in the hospital, whether that's inpatient or observation, doesn't really matter. It's what was learned during that stay and to how you might code that.
There was one last question that was in the chat, and it was asking if the inpatient only list could only be used for Medicare patients or if it could be used by commercial insurances too. The CMS only inpatient only list is used for Medicare patients. However, it is encouraged to be adopted by commercial payers.
Any other questions from the audience today? Well, we are finishing up much sooner than we anticipated. But for those of you on the phone, Trend prides itself in their relationships with their clients and would love to meet with you if you are going to be at any of these HFMA conferences or the Class Awards show. We've given the dates here of those. We'd love to set up a call meeting with you, maybe catch a coffee or either lunch or dinner with you during this time. Let us know, and we will definitely reach out prior to the meeting and be glad to get in touch, have face to face. If there are no more questions or comments, we will conclude today and appreciate those that were in attendance. Thank you.